Hi everyone, our subject today is acidemia in pediatrics. Basics. Acidemia is a blood pH level less than 7.35. Excessive acidity of body fluid, acidosis, may be acute or chronic, primary metabolic decreased plasma bicarbonate, or primary respiratory increased partial pressure of CO2. It may occur as part of mixed acid-base disorder. History. In acute acidosis, inquire about diarrhea or other GI losses, medication, and possibility of ingestion. In young infant, a history of poor feeding, failure to thrive, vomiting, lethargy, or seizure may indicate an inborn error of metabolism. Poor growth may be a clue to renal tubular acidosis in older children. Non-specific symptoms of acidosis may include hyperventilation and cosmal breathing, deep rapid respiration. Unusual breath odor may suggest diabetic ketoacidosis or ingestion. How to approach to acidemia in pediatric after performing history and physical examination. Patient need arterial blood gas analysis, serum electrolyte, urine pH, urine electrolyte, serum osmolality. If the PCO2 more than 40, this is respiratory acidosis. Differential diagnosis: airway obstruction, laryngeal edema, croup, epiglottitis, foreign body, aspiration, severe bronchospasm, cystic fibrosis, bronchopulmonary dysplasia, interstitial lung disease, pneumonia, pulmonary edema, pleural effusion, pneumothorax, thoracic cage abnormality, Pickwickian syndrome, neuromuscular disease, and CNS depression. If the PCO2 less than 40, calculate anion gap. If it is metabolic acidosis with the elevated anion gap, is there suspicion of toxic ingestion? If it is yes, calculate osmolar gap. If it is elevated osmolar gap, differential diagnosis: ethylene glycol ingestion or methanol ingestion. If it is normal osmolar gap, or there is no suspicion of toxic ingestion with the metabolic acidosis and elevated anion gap, differential diagnosis: ingestion, paraldehyde, salicylate, metformin, ketoacidosis, diabetic ketoacidosis, lactic acidosis, organic acidemia, methylmalonic acidemia, propionyl-CoA carboxylase deficiency, methionine administration, and renal failure. If it is metabolic acidosis with normal anion gap, is there hyperkalemia present? If it is yes, this is type 4 renal tubular acidosis, adrenal disorder, Addison disease, congenital adrenal hyperplasia, primary hypoaldosteronism, obstructive uropathy, pyelonephritis, interstitial nephritis, diabetes mellitus, nephrosclerosis, pseudo-hypoaldosteronism, drugs, chronic renal failure. If there is no hyperkalemia, obtain urine pH with the urinary anion gap. If the urine pH more than 5.5, differential diagnosis: distal RTA type 1, proximal RTA in mild acidosis, carbonic anhydrase inhibitor, acetazolamide, dilutional acidosis, late metabolic acidosis of prematurity. If the urine pH less than or more or equal to 5.5, differential diagnosis: diarrhea, other bicarbonate losses, tube or fistula, drainage, urethral diversion, ileal pouch, proximal RTA in severe acidosis, ingestion of chloride-containing compound like HCl, NH4Cl, arginine HCl, lysine HCl, anion exchange racine, which is cholecystramine, hyperelimination, carbonic anhydrase inhibitor like acetazolamide. The diagnosis is made by laboratory value: the pH reflecting extracellular free hydrogen ion concentration, partial pressure of CO2, and plasma bicarbonate level HCO3 are considered in a clinical acid-base disorder. Their relationship is described by this modified version of Henderson-Hasselblad equation: hydrogen ion equal to 24 multiplied by PCO2 over HCO3. When the carbonate level is decreased, an increased respiratory rate occurs as a compensatory mechanism to try to maintain a normal pH. Renal compensation, secretion of excess hydrogen ion, and the reabsorption of bicarbonate is necessary to ultimately correct the acidosis, because the lungs cannot create an absolute loss or gain of hydrogen ion. In mixed acid-base disorder, a combination of simple disorder occur, such as in child with the chronic lung disease who experience a combined metabolic alkalosis and respiratory acidosis. Guidelines exist for expected renal and respiratory compensation of acidemia. Mixed disorder should be suspected when the compensatory response differs from the predicted response. Compensation never overcorrect the pH and rarely correct the pH to normal value. Urine pH and urine electrolyte should be included in the preliminary analysis of RTA is suspected. Serum osmolarity value will aid in narrowing the diagnosis of metabolic acidosis when an increased anion gap. Neuromuscular disorder that can result in respiratory acidosis include brainstem or spinal cord disorder, including tumor, Guillain-Barré syndrome, polio, myasthenia gravis, muscular dystrophy, botulism, encephalopathy, and drugs, depressant, sedative. The anion gap reflects and measures anion, which is in combination with the bicarbonate and chloride, counterbalance the positive charge of the sodium ions. Anion gap equal to sodium, which is the positive, minus chloride plus carbonate. The normal anion gap is 4 to 11 milliequivalent per liter, although variation exists among laboratories. Elevation occurs secondary to an excess accumulation of acid, endogenous or ingested, or inadequate excretion of acid. Hyperchloremia occurs in metabolic acidosis with the normal anion gap. An anion gap lower than expected may occur in presence of hyperkalemia, hypercalcemia, hypoalbuminemia, hypermagnesemia, bromide intoxication, or laboratory error. Ingestion should be suspected in young children or depressed adolescents at risk for suicide with an acute onset of symptom, usually multisystemic, a history of previous accidental ingestion, or an altered level of consciousness. A difference of greater than 10 to 15 millismol between the measured serum osmolarity and calculated serum osmolarity suggests unmeasured osmotic particles like methanol, ethylene glycol. Calculated serum osmolarity 2 multiplied by sodium plus potassium plus blood urea nitrogen divided by 2.8 plus glucose level over 18. Ethylene glycol, radiator antifreezer ingestion cause neurologic symptom, respiratory failure, cardiovascular collapse, and renal failure. The increased anion gap is due to the accumulation of the metabolic formic acid. Lactic acidosis also frequently occur. Methanol, wood alcohol ingestion causes GI and neurological symptoms, and severe blinding retinitis can also occur. The anion gap is due to a metabolites, glycoxylic acid, formic acid, and oxalic acid. Lactic acidosis also occur. Salicylate ingestion in children is characterized by neurological symptoms, coma, altered mental status, seizure, and hyperventilation. Fever may be prominent in infant. Younger children are more susceptible to metabolic acidosis. Respiratory alkalosis is the predominant acid-base abnormality in older patients. Starvation, glycogen storage disease type 1, and inborn error of amino acid or organic acid metabolism are less common cause of ketoacidosis. Lactic acidosis with the blood lactate level of 5 milliequivalent or higher most commonly is due to hypotension, hypovolemia, or sepsis. Other causes include exercise, ethanol ingestion, and inborn error of metabolism, particularly mitochondrial and disorder of carbohydrate metabolism. An increased anion gap in renal failure occurs because impaired hydrogen excretion prevents appropriate regeneration of carbonate. Anions such as sulfate and phosphate also accumulate. Hyperkalemia can develop without the effect of aldosterone. It may be due to primary aldosterone deficiency or result from acquired kidney disease, resulting in low ricin level. Type 4 RTA, characterized by deficiency of or impaired distal tubular response to aldosterone. In pseudohypoaldosteronism, both renin and aldosterone level are elevated, but the response of the distal tubule to the aldosterone is impaired. Certain medication, potassium-sparing diuretics, non-steroidal anti-inflammatory drugs, beta-blocker agent, angiotensin-converting enzyme inhibitor, cyclosporine, can cause a functional hypoaldosteronism. Urine pH should be measured on a fresh urine specimen. Serum electrolyte should be collected at the same time for the bicarbonate level. The urine specimen can be taken for any time, but should be obtained while the patient is still acidotic. The urine pH reflects only free hydrogen ion, less than 1% of the total hydrogen ion excreted. It is often helpful to consider it in conjunction with the measure of net acid excretion, primarily urine ammonium concentration, synthesis of ammonia, and its subsequent excretion of ammonium are increased in most cases of systemic acidosis. The urinary anion gap is used to estimate the production of ammonium ion. Urine anion gap, urine sodium plus urine potassium minus urine chloride. The lower or more negative the gap, the greater the acid secretion in the form of ammonium. RTA is characterized by an inability to adequately acidify the urine in the presence of normal anion gap, hyperchloremic acidosis. It may occur primarily or associated with a multiple inherited disorder or acquired systemic disorder. In the distal and proximal subtype, volume concentration results in aldosterone-mediated hypokalemia. In distal type 1 or classic RTA, permanent deficiency of hydrogen ion secretion by the distal tubule results in wasting of the portion of the filtered load of bicarbonate. The bicarbonate wasting persists even in the presence of severe systemic acidosis. Urine pH is never more acidic than 5.8. The urine anion gap is a small or low negative value. In proximal RTA type 2 or bicarbonate wasting, a defect in the proximal tubular reabsorption of carbonate results in higher load of bicarbonate being presented to the distal tubule. In mild acidosis, this excess carbonate is lost in the urine because its amount exceeds the capacity of the distal tubule for reabsorption in the normal distal tubule. In more severe acidosis, a lower amount of bicarbonate is filtered and is able to be reabsorbed in the normal distal tubule. Because distal acidification mechanisms are intact in proximal RTA, urine pH will become more acidic. pH more than 5.5 under these circumstances. The urine anion gap is high negative value regardless of the severity of duration of the acidosis. Accompanying hypokalemia can be severe. Rapid volume expansion with non-bicarbonate containing solution can cause transient small bicarbonate losses in the urine. Premature infant and neonate with renal function that is normal for maturation may demonstrate mild metabolic acidosis due to a transient reduced threshold for bicarbonate reabsorption. This normally corrected by 4 to 6 weeks in the premature infant and by 3 weeks in term infant. Increased bicarbonate losses in diarrhea can contribute to metabolic acidosis. Thank you for your listening.